Hey guys, welcome to the new video of our endocrinology series. So in this video, we'll be discussing about hypothalamus and pituitary and why this matters in the exam. So in this video, we're going to study the hypothalamus and pituitary axis, which is the master control system of the endocrine system. This axis, this hypothalamus and pituitary axis, connects the nervous system to the endocrine system and controls most other endocrine glands in the body. If you understand how this axis works, you'll be able to interpret many complex hormone patterns very easily. For USMLE, this axis is extremely important because it explains feedback loops, which is very important. Then hormone hierarchies, and also many classic laboratory patterns. So, understanding this topic helps you understand a major part of endocrinology. Okay, so you can watch this at 1.5x if you would wish to do that. So, before beginning with the video, I would like to request all of you to please subscribe and keep supporting. This is an open access platform. If you find it useful and wish to support its development, voluntary contributions are welcome, and you can pay with the link that is on the slide and also pinned in the description. Uh, any contribution will be welcome. Thank you. So, so we already discussed. The feedback loops is what are going to understand, the hormone hierarchies and interpretation of laboratory patterns. So these three will be the most important aspect of endocrinology, and this is a gateway for this. So hypothalamus pituitary axis regulates most endocrine glands, and it links the nervous system with the endocrine system, and it also explains many complex hormone patterns. So if you understand this axis, a large part of endocrinology becomes simple. Most endocrine systems are organized into three levels. So at the top is the hypothalamus, which releases either uh, stimulating or inhibitory hormones. The pituitary sits in the middle and releases tropic hormones. The target gland is at the bottom and releases the final hormone that produces the clinical effect. For example, the hypothalamus releases TRH, the pituitary releases TSH, and the thyroid releases T3 and T4. Disease can occur at any of these three levels, at the level of the hypothalamus, or at the level of the pituitary, or at the level of the thyroid. And USMLE often tests your ability to identify at which level is the disease affecting your endocrine system. The pituitary gland has two different embryological origins. So the anterior pituitary develops from the Radke pouch, whereas this Radke pouch comes from the oral ectoderm. The posterior pituitary develops from the neuroectoderm, and it grows down from the brain. This difference in origin explains how diseases of anterior and posterior pituitary behave differently. The USMLE loves this concept because it links embryology to pathology. Yeah. One classic clinical correlation is craniopharyngioma, which arises from the remnants of the Rathke's pouch. This craniopharyngioma can cause, this is a tumor, and this can cause headache, visual problems, and multiple endocrine deficiencies. Because the anterior and the posterior pituitary have different origins, they also have different disease patterns, different hormones, and different mechanisms. If you know the embryological origin, you can often predict the behavior of the disease. If you know the origin, you can predict the behavior of the disease. Coming to anatomy, the pituitary gland lies in the sella turcica and sits just below the hypothalamus. It is very close to the optic chiasm. This is clinically important because pituitary tumors can compress the optic chiasm and can cause bitemporal hemianopia. They can also compress the normal pituitary tissue and can cause hormonal deficiencies. So, if a patient has headache, visual field defects, and endocrine symptoms, you should think about a pituitary mass. So, anterior pituitary origin is from the Rathke's pouch, whereas posterior pituitary origin is from the neuroectoderm. Rathke pouch in turn originates from the oral ectoderm. All right, it is just uh, lying in the bony cavity called as sella turcica, just below the hypothalamus, and it is very close to the optic chiasm, is what we have studied. So, any tumor in this pituitary can compress the optic chiasm and can cause visual field effects. So this is a very important clinical correlation. Uh, Coming to blood supply, the anterior pituitary has a unique blood supply called as the hypophyseal portal system. Hypothalamic hormones are released into capillaries at the median eminence, and they travel through the portal veins and then reach the anterior pituitary to control hormone secretion. This means that the hypothalamus controls the anterior pituitary through blood. Hypothalamus controls the anterior pituitary through blood, but not nerves. Hypothalamus releases hormones at the median eminence. They travel through the portal veins and reach the anterior pituitary and controls pituitary hormone secretion. So it acts through blood, not through nerves. Why the portal system is important? So this portal system allows very small amounts of hypothalamic hormones to have powerful and precise effects on the pituitary hormone secretion. So if the blood supply is damaged, anterior pituitary hormones will decrease. The posterior pituitary is less affected because it has a direct neural supply and a direct neural connection. So we have to remember that the anterior pituitary depends on blood supply, whereas the posterior pituitary depends on the nerves. Now we'll try to understand the key and functional difference between anterior and posterior pituitary. The anterior pituitary is a glandular tissue and actually synthesizes its own hormones. It is controlled by the hypothalamic hormones through the portal system, as we have already discussed. Whereas the posterior pituitary, on the other hand, it is a neural tissue and hormones are made in the hypothalamus. These are not made by the pituitary itself, but these hormones are made in the hypothalamus and transported down the axons, and then they're stored and then release it from the posterior pituitary. So posterior pituitary does not synthesize hormones. Coming to the hormones of the anterior pituitary, we can memorize those hormones using the mnemonic flat pig. So the anterior pituitary secretes six major hormones. They include FSH, LH, ACTH, TSH, prolactin, and growth hormone. Flat pig. FSH, LH, ACTH, TSH, prolactin, and growth hormone. Uh, so mnemonic is flat pig. Okay. Most pituitary questions on the USMLE involve one of these hormones, so we should memorize this list: FSH, LH, ACTH, TSH, prolactin, and growth hormone. So coming to the hormones of the posterior pituitary, the posterior pituitary releases only two hormones, ADH, also called as vasopressin, and the other one is oxytocin. Both these hormones are synthesized in the hypothalamus and then they're transported to the posterior pituitary for storage and release. So the posterior pituitary is the storage and the release site. It is not a site for synthesis. So ADH and oxytocin, these are just stored and released by the posterior pituitary, but these are not generally synthesized by the posterior pituitary itself. These are synthesized in the hypothalamus, transported down the axons, and they are stored and they are released from the posterior pituitary. Coming to the hypothalamic hormones, the hypothalamus controls the anterior pituitary using releasing and inhibiting hormones. All right, using releasing and inhibiting hormones. So TRH stimulates TSH, CRH stimulates ACTH, GnRH stimulates FSH and LH, GHRH stimulates growth hormone. Somatostatin inhibits growth hormone and uh, TSH. And dopamine inhibits prolactin. So a very important rule is that prolactin is mainly under inhibitory control by dopamine. So prolactin inhibitory factor is the other name for dopamine. So we have to remember this. So coming to regulation of prolactin. So prolactin is unique because it is tonically inhibited by dopamine. If dopamine is removed, prolactin levels automatically they rise. So TRH can increase prolactin. Thyrotropin releasing hormone can increase prolactin, and stress and pregnancy can also increase prolactin. Clinically, dopamine agonists decrease prolactin. I've already told you that dopamine is nothing but prolactin inhibiting factor, PIF. So when dopamine agonists are used, it leads to decreased prolactin. When dopamine antagonists are used, it leads to increased prolactin because of reduced or antagonized inhibitory effect of on prolactin. So uh, removing dopamine means the prolactin goes up. Growth hormone is regulated by two opposite opposing signals. So growth hormone increases, GHRH increases growth hormone, whereas somatostatin decreases growth hormone. Sleep, exercise, and stress and hypoglycemia increase growth hormone, whereas hyperglycemia decrease growth hormone. Uh, Growth hormone secretion is pulsatile, it is not constant, which is important. So this is important for testing and diagnosis. Coming to the feedback loops in hypothalamic and pituitary axis, most pituitary hormones are regulated by negative feedback. For example, CRH stimulates ACTH, which stimulates cortisol. CRH stimulates ACTH, which stimulates cortisol. Okay, and cortisol feeds back to inhibit both CRH and ACTH. So from the hypothalamus, CRH release leads to ACTH release from the pituitary, and this ACTH from pituitary leads to cortisol release from the adrenal. This cortisol release in turn leads to feedback, negative feedback on ACTH and CRH at the pituitary and hypothalamus level, respectively. So there is a negative feedback. Uh, so this is one of those feedback loops we have to understand. Most pituitary hormones are regulated by negative feedback. High target hormone usually means low upstream hormones. In general, high target gland hormone levels suppress upstream hormones, and low target gland hormone levels increase upstream hormones. So when cortisol increases, it leads to decreased ACTH and CRH. When cortisol increases, it leads to decreased ACTH and CRH, and when cortisol decreases, it leads to increased ACTH and CRH. To summarize, hypothalamus uses releasing and inhibiting hormones to control the anterior pituitary. Prolactin is mainly under dopamine inhibition. Prolactin is mainly under dopamine inhibition. Growth hormone is controlled by growth hormone, regulatory hormone, releasing hormone, and somatostatin. Feedback loops explain most endocrine lab patterns. So it's very important that we need to understand how the feedback works at the hormonal level. Coming to pituitary adenomas are the most common cause of pituitary hormone excess. They cause problems in two main ways. So, by secreting too much hormone and by causing mass effects such as, headache and visual field effects and hypopituitarism due to compression of the normal pituitary tissue. So, whenever there's hormone excess plus mass effect, you have to suspect pituitary tumors or pituitary adenomas. Pituitary adenomas are an example of pituitary tumors. So any glandular tumor is called as an adenoma. That's what we have already known from whatever we have learned previously. So pituitary adenomas are the most common cause of pituitary hormone excess problems in two ways: high hormone hypersecretion, hormone excess, and also mass effect, compression of the nearby structures, which can lead to headache, visual field effects, and hypopituitarism due to compression of the normal pituitary. So now coming to prolactinoma, which is the most common pituitary adenoma. Uh, yeah, Prolactinoma is the most common pituitary adenoma. High prolactin causes galactorrhea, amenorrhea, infertility, decreased libido, and erectile dysfunction. Prolactin inhibits gonadotropin releasing hormone, which explains many of these symptoms. So whenever there is high prolactin, this leads to inhibited GnRH, and inhibited GnRH in fact leads to inhibited FSH and LH. This causes hypogonadism symptoms like decreased libido, erectile dysfunction, amenorrhea, infertility, and high prolactin also causes galactorrhea, excess secretion of milk. So causes of high prolactin. High prolactin is can be caused by prolactinoma, dopamine antagonists such as antipsychotics and metoclopramide, hypothyroidism by increased TRH, pregnancy and stress, and pituitary stalk compression. The stalk uh, section effect causes loss of dopamine inhibition, and therefore it increases prolactin. So whenever there is a compression of the pituitary stalk, there is loss of dopamine, and this leads to increase of prolactin. Treatment of prolactinoma. The first line treatment of prolactinoma is medical therapy with dopamine agonists such as bromocriptine or cabergoline. So these drugs decrease prolactin levels, shrink the tumor size, and restore fertility and sexual function. Surgery is not the first line. Medical management is the first line therapy or treatment for prolactinoma. Now let's try to understand the main differentiation between acromegaly and gigantism. Both are due to growth hormone excess. Both acromegaly and gigantism are caused by excess growth hormone, usually from a pituitary adenoma. Gigantism occurs before epiphyseal closure uh, and causes extreme height. Acromegaly occurs after epiphyseal closure and causes enlarged hands, feet, jaw, and coarse facial features. So the disease is same, but the timing is different. So one before epiphyseal closure and the other after epiphyseal closure. The common features of both the conditions includes enlarged hands. Common features of acromegaly includes enlarged hands and feet, coarse facial features, arthralgia, and cardiomegaly. Timing is the difference. In acromegaly, we test IGF-1, insulin-like growth factor 1, not growth hormone itself, because growth hormone is secreted in pulses. So a single growth hormone level is unreliable. We understand that when it is secreted in pulses, it may be more or less at the time of testing. It may be even either more or it can be either less than the basal rate. So it is secreted in pulses and fluctuates during and throughout the day. So a single value is unreliable for diagnostic testing. IGF is produced in the liver in response to growth hormone, and this IGF-1 has a stable blood level. Therefore, we screen for acromegaly using IGF-1, not growth hormone, because it reflects average growth hormone activity. Whereas confirming acromegaly, we have to do it using the oral glucose test. Normally, glucose intake suppresses the growth hormone. In acromegaly, growth hormone is not suppressed. So after giving oral glucose, a failure of growth hormone suppression confirms the diagnosis of acromegaly. After giving oral glucose, failure of growth hormone suppression confirms the diagnosis of acromegaly. So what normally happens after glucose intake is there is suppression of growth hormone secretion after glucose intake in normal. This is the normal physiology. Whereas in acromegaly, this growth hormone is not suppressed. So this can be confirmed using first we have to give oral glucose and then we measure the growth hormone levels. What normally happens if it's in a normal physiological condition, what happens is that whenever there is glucose intake, there is decreased growth hormone levels. Whereas in acromegaly, even after giving oral glucose, there is elevated growth hormone and there is also failure of growth hormone suppression. So this can be a diagnostic indication for acromegaly. So high insulin-like growth factor is a screening diagnostic test, and oral glucose test is a confirmatory test for acromegaly. Now, coming to treatment of acromegaly, the main treatment is transsphenoidal surgery to remove the pituitary adenoma. Somatostatin analogs are additional treatment. These includes octreotide and lanreotide, growth hormone receptor antagonists, and sometimes dopamine agonists are also used. So, surgery is primary, but drugs are adjuncts in cases of treatment of acromegaly. Hypopituitarism means a deficiency of one or more pituitary hormones. So the common causes includes pituitary adenoma compression, Sheehan syndrome, uh, Sheehan syndrome, craniopharyngioma, radiation, and surgery. So the clinical features depend on which hormones are deficient. The clinical features of any of these conditions depends on which hormones are deficient and how quickly the deficiency develops. What's the speed of onset of the deficiency? So common causes of pituitarism includes pituitary adenoma compression. We have already discussed. Stalk compression is what we have discussed. And then there's Sheehan syndrome and then craniopharyngioma, radiation and surgery. The usual order of hormone loss and hormone loss is growth hormone first, then FSH and LH, then TSH, then ACTH, and prolactin is usually the last to be lost, or it's even preserved because it is under inhibitory control. So this prolactin is under uh, all these are under stimulatory control mostly, whereas this prolactin is under inhibitory control from dopamine. So prolactin is often last to be lost because it is under inhibitory control. Now let's discuss about water balance in our body. So ADH is synthesized in the hypothalamus and is released from the posterior pituitary. It acts on the kidney collecting ducts to increase water reabsorption. So problems with ADH cause problems with serum sodium and urine concentration. Diabetes insipidus is a condition where the body cannot concentrate urine. Patients have polyuria, polydipsia, and dilute urine or low urine osmolality is seen. There are two main types in diabetes insipidus. Central diabetes insipidus, where there is not enough ADH, whereas in nephrogenic diabetes insipidus, the kidneys do not respond to the already secreted antidiuretic hormone. Central, there is not enough ADH, whereas nephrogenic, the kidneys do not respond to ADH. It is already present in the bloodstream. So both these cause dilute urine, but the cause is different. In central diabetes insipidus, the problem is low ADH production or release, and it is treated with desmopressin. In nephrogenic diabetes insipidus, the problem is renal resistance to ADH. It is commonly due to lithium, hypercalcemia, or kidney disease. Uh, Treatment is desmopressin does not work. It works in case of central diabetes insipidus, but in the case of nephrogenic diabetes insipidus, this desmopressin doesn't work. So we have to treat the cause firstly. Why did the kidneys develop resistance to ADH? We have to treat the cause, and then we can use thiazides and for management, and low salt diet is usually advised to patients with nephrogenic diabetes insipidus. So the causes of central diabetes insipidus includes head trauma, surgery, tumors, and idiopathic conditions, other idiopathic conditions. So central diabetes insipidus responds to desmopressin, nephrogenic diabetes insipidus does not. So this is the key difference. SIADH, or syndrome of inappropriate ADH secretion, is the opposite of diabetes insipidus. In this condition, the problem is that there is too much ADH, leading to water retention, hyponatremia, low serum osmolality, and inappropriately concentrated urine. So the common causes includes small cell lung cancer, CNS disease in certain drugs. So the USMLE pattern in identifying a question of SIADH is whenever there is low sodium and concentrated urine. We have discussed in diabetes insipidus, there is dilute urine, there is low urine osmolality. Whereas in the case of SIADH, there is concentrated urine. Whenever there is low sodium and concentrated urine, we have to think about syndrome of inappropriate antidiuretic hormone secretion. The features includes hyponatremia, low serum osmolality, and inappropriately concentrated urine or highly concentrated urine. Causes include small cell lung cancer, CNS disease, and certain drugs. Now let's try to differentiate between diabetes insipidus and syndrome of inappropriate antidiuretic hormone secretion. In diabetes insipidus, urine is dilute. Serum sodium is high or normal, whereas in SIADH, urine is concentrated and serum sodium is low. We have to always compare serum sodium and urine concentration levels whenever we try to differentiate between diabetes insipidus and syndrome of inappropriate antidiuretic hormone secretion. So now let's discuss about water deprivation test. So this water deprivation test is used to differentiate between primary polydipsia and diabetes insipidus, and it helps to distinguish central diabetes insipidus from nephrogenic diabetes insipidus. So the basic idea is that in normal physiology, urine becomes concentrated when water is withheld. So normal physiology, what happens is urine becomes concentrated when water is not being filtered too much. What happens whenever we drink very less water, or whenever there's a case of dehydration, what happens to our urine? It seems to be very highly concentrated. So that's the normal physiology. Whereas in diabetes insipidus, urine stays dilute despite dehydration. Even though there is dehydration, even though there is low water intake, even in that case, in diabetes insipidus, urine still stays dilute. It doesn't get concentrated as it has to happen in normal physiology. Urine still stays dilute. So if urine does not concentrate after water deprivation, ADH action is impaired. Is what we have to understand. So now let's try to understand water deprivation testing. So in step one, first the water is withheld. Water is withheld and urine osmolality is measured. Then desmopressin is given. In central diabetes insipidus, uh, urine osmolality increases after desmopressin. We have already discussed that desmopressin acts in the cases of central diabetes insipidus, whereas cases of nephrogenic diabetes insipidus, this desmopressin is unresponsive. This is not the mainstay of treatment, whereas in central diabetes insipidus, desmopressin is the mainstay of treatment. So then we give a desmopressin and we have to measure urine osmolality again. If if there is increase of urine osmolality after giving desmopressin, we have to suspect central diabetes insipidus. In nephrogenic diabetes insipidus, urine osmolality does not increase. So in primary polydipsia, what happens is urine concentrates with water deprivation alone. Urine concentrates with water deprivation alone. There is no need of nothing anything else. So if there's a response to desmopressin, we have to suspect central diabetes insipidus. Now, trying to understand the treatment of diabetes insipidus, central diabetes insipidus is treated with desmopressin. Nephrogenic diabetes insipidus is treated by addressing the cause using thiazide diuretics and giving a low salt diet. Desmopressin works in central DI, not in nephrogenic DI. Treatment of SIADH. SIADH is treated with fluid restriction and careful correction of sodium. Uh, Vaptans, the drugs called Vaptans, which are also ADH receptor antagonists. So these Vaptans are useful, and sometimes demeclocycline is also useful in treating SIDH. So this sodium must be corrected slowly to avoid central pontine myelinolysis. So when you correct the sodium levels very fast, what happens is there is a risk of central pontine myelinolysis. There is a risk of myelinolysis whenever there's sodium correction that is happening too fast. So whenever you are correcting sodium, you need to take it up in a stepwise manner, and you shouldn't correct sodium too fast. Chronic hyponatremia, we have to correct it slowly. Posterior pituitary disorders, key takeaways. So now let's discuss about this. See, ADH controls water balance. Diabetes insipidus is due to too little antidiuretic hormone effect, while SIADH is due to too much antidiuretic hormone. The water deprivation test and desmopressin response helps us distinguish between different causes of uh, uh, water balance disorders. Coming to pituitary pharmacology, pituitary drugs are mainly used to decrease excess hormone secretion and replace deficient hormones or block hormone secretion at the receptor, hormone action at the receptor level. The most commonly tested targets are prolactin excess, growth hormone excess, and ADH disorders. The USMLE focus whenever it's related to pituitary pharmacology is that we need to know which drug is used for which hormone problem. Dopamine agonists such as bromocriptine and cabergoline are used to treat hyperprolactinemia in case of prolactinoma. They decrease the prolactin levels, they shrink the tumor size, and restore fertility and sexual function. They are the first line therapy for prolactinoma. Somatostatin analogs such as octreotide and lanreotide inhibit growth hormone release, and these are used in cases of acromegaly, especially and some neuroendocrine tumors. In case of acromegaly, especially when surgery is not sufficient to treat acromegaly, we have to consider using somatostatin analogs like octreotide and lanreotide. Desmopressin is an antidiuretic hormone analog that is used to treat central diabetes insipidus. Vaptans are ADH receptor antagonists, which are used in SIADH. So, central diabetes insipidus gets desmopressin. SIADH is treated with Vaptans or fluid restriction. To summarize, hypothalamus controls the pituitary through blood and nerves. The anterior pituitary secretes hormones. In the mnemonic, we have to remember it as flat pig, FSH, LH, ACTH, TSH, prolactin, and growth hormone. Posterior pituitary releases ADH and oxytocin. Prolactinoma is the most common pituitary adenoma. Acromegaly is screened with insulin-like growth factor 1 and is confirmed by oral glucose test. Diabetes insipidus and SIADH are opposite water balance disorders with opposite lab patterns. So that's the key differentiating features between SIADH and DI are the focus point in any kind of examination. Dopamine agonists, somatostatin analogs, desmopressin, and Vaptans are the main drugs that we have discussed in this video. So this series, this endocrinology series, totally contains 6 videos, and in the next chapter, and in the next video, we'll try to understand uh, thyroid and parathyroid, and also disorders related to them. Thank you. Subscribe and keep supporting and keep waiting for the next video. Thank you. Bye.